Hi everyone, this is Dr. Jake Pace.
And I'm Dr. Samir Mall.
This is your screencast on rapid sequence intubation in preparation for the airway day. Over the next hour, Samir and I are going to take you through the preparation and steps to performing an RSI.
The objectives for this lecture are pretty straightforward. We'll start off with defining RSI and then progress to describing what's commonly known as the 7 Ps to help you progress through the steps of planning the RSI appropriately. And then lastly, we'll take you through salvage mode when your first attempt at laryngoscopy fails. So starting off with the definition of rapid sequence intubation, it's pretty straightforward in that it's a procedure for endotracheal intubation in which you administer a potent induction agent followed immediately by a rapid-acting neuromuscular blocking agent when in a goal to produce a state of unconsciousness and paralysis, and you do not typically intervene with ventilations during the apneic period. It was originally devised as a method to reduce aspiration in non-fasted patients, but has now progressed to being the generally safest accepted means to emergently control a patient's airway. The benefit of performing an RSI is that there's no gastric insufflation, and it allows you to rapidly gain airway control. The risks of it are that if you administer a neuromuscular blocking agent and are subsequently unable to pass an endotracheal tube, you have a situation where you have a patient who's apneic with an unprotected airway. The contraindications are predictors of difficult laryngoscopy and difficult backup methods, which we'll take you through shortly.
We next wanted to talk about how you decide to get to an RSI. What this lecture is not going to discuss is the overall decision to intubate, the different indications, different reasons you would intubate a patient. We're talking about how you get to the point where you decide an RSI is the most appropriate and safest way to control a patient's airway. The first step in this is deciding if this patient has predictors of a difficult airway. If you've decided a patient has predictors of difficult airway, then the next step is deciding whether there's predictors of difficult bag valve mask ventilation or extraglottic device placement. If you decided that both the airway is going to be difficult to control, and we'll discuss in the next few slides different strategies to predict difficulty with laryngoscopy or bag valve mask ventilation, and you've also decided they're going to be difficult to bag valve mask or place an extraglottic device, you'll proceed with an awake intubation. If you decide the airway is not difficult, or if the laryngoscopy will be difficult but bag valve mask ventilation is predicted to be easy, then we would proceed towards an RSI. And then if your RSI fails, then we are in a salvage airway mode, which we'll review at the end of the lecture.
So difficult laryngoscopy. We've all probably heard of the lemon mnemonic for predicting difficult laryngoscopy. And just going through it very quickly, starting with L, at the end of the day, it ends up being a bit of a gut feeling that you get. Unfortunately, research studies looking at Lemon's ability to accurately predict difficult airways have been mixed in that in and of themselves, each of these criteria are not necessarily the best predictors, but taken as a whole can at least make the practitioner think about the airways. So we're going to look externally and just get that gut feeling if someone looks like they may be anatomically difficult. Next, we're going to evaluate the 332, which in essence helps us determine whether the geometry for this patient will facilitate a direct line of sight. Is the mouth going to open enough to permit visualization past the tongue? Is the mandible of a sufficient size to push the tongue out of the way? And is the glottis located sufficiently caudate to the base of the tongue so that you can create that line of sight? We're going to look for a Mallampati score to just check for basic room in the mouth. Look for signs of obstruction or obesity. Does this patient have any dysphonia or dysphagia, which potentially could suggest neck pathology, which may make passing a tube more difficult? And is this patient's neck mobile, and will the patient be able to aid us in getting them in an appropriate intubating position to create that direct line of sight?
The next mnemonic we wanted to review was one to predict difficult bag valve mask ventilation. This mnemonic is Roman, and there's some common themes in terms of predictors of difficulty from laryngoscopy to bag valve mask ventilation to supraglottic device deployment. However, it's important to have an element of a structured assessment to predict the difficulty of each of these different airway maneuvers. So Roman stands for, R stands for radiation or restriction. Is there any resistance to mouth opening or radiation to the upper airways that may make deploying or providing positive pressure ventilation difficult? Is there any issues with pulmonary compliance that will make distension of the lungs difficult? O stands for obesity, obstruction, or OSA. Once again, the increased weight in the chest or abdomen or redundant tissues in the neck or mouth can provide difficulty with bag valve mask ventilation. M stands for mask seal. Are you going to have issues with performing a mask seal in this patient? Is there beard? Is there blood? Is there a lot of trauma to the face? Age stands for people above the age of 50. You lose tissue tone and cheeks can become redundant, and as you try to bag valve mask a patient, soft tissues can obscure the airway. And N stands for no teeth for support for the mask seal.
Next, going to difficult supraglottic placement. So this is the next step in trying to rescue yourself if you're unable to get an airway. Am I going to have a difficult time placing any of a myriad of extraglottic devices? So in general, mouth restriction is key. So the mouth needs to open wide enough that you're able to insert one of these devices, all of which tend to be rather bulky. Secondly, is the patient have any upper airway obstruction, which would preclude ventilation with the SGD, or are there redundant tissues either in the posterior pharynx or on the chest, which would require high airway pressures, which may not be able to be generated with a supraglottic device? Is there any sort of distorted anatomy from previous surgeries or radiation, which would make seal difficult? And then lastly, a short thyromental distance, which is basically a small mandibular space, which would mean that there's not enough room to insert your SGD.
Although in the previous slides, in terms of decision making, we did not talk about cricothyrotomy, it is important to consider this, as this is your last step in emergency airway management, and having an assessment of difficult cricothyrotomy is important. The mnemonic here is SMART. S stands for surgery, is a previous scarring, distortion of the upper airway, which would make localizing the larynx difficult. M stands for mass, is there an abscess or a hematoma overlying the anterior neck structures, which would provide difficulty in terms of finding the larynx. A is axis or anatomy. Is the patient obese? Do they have a short neck? Do they have significant subcutaneous emphysema, which will impair your ability to perform a cricothyrotomy? R stands for radiation. Is there significant scar tissue, which will make dissecting the tissue planes difficult? And T stands for tumor. Will this impair your access to the larynx, or will this provide significant bleeding, which impairs your ability to perform this procedure? So we are at the stage where you have decided this patient needs to be intubated, and they either do not have a difficult airway, or they do have a difficult airway in terms of laryngoscopy, but you've decided that you can safely bag valve mask the patient or place an extraglottic device, and you're going to proceed with a rapid sequence intubation. We're now going to take you through the steps of preparation for this airway procedure.
All right, so first to start off with, are you ready to perform an RSI? This is a very can be potentially a very dangerous procedure, and it's necessary that you've set your team, your patient, your environment, and your equipment up in a fashion so that you and your team are prepared for anything that may come. Typically, this has been thought of as the 7 Ps of RSI, which are kind of a series of discrete steps in order to successfully perform this procedure. Although it's helpful contextualizing an RSI as these 7 discrete steps when you're teaching junior residents or talking to your team, most emergency situations require that each of these 7 steps are occurring simultaneously. First off, starting with preparation, and this is, do I have the minimum standard level of equipment that I would require to perform laryngoscopy, deliver a tube, rescue myself from a difficult situation, provide adequate oxygenation and ventilation for a patient during the procedure. So this is essentially just boils down to all the stuff that you're going to need. I'm not a big fan of mnemonics, but one here that is commonly taught is called SOAPME, suction, oxygen, airway stuff and equipment, making sure your patient is positioned in an appropriate manner if possible, monitoring equipment and your medications, and then lastly, end tidal capnography to confirm placement. More so than mnemonics, I'm a big proponent of airway checklists that are standard of care in advanced pre-hospital teams around the world. And essentially, these airway checklists are meant to offload some of the simpler parts of an RSI, like preparing equipment, so that the team can really focus around the more difficult aspects of the case, like making sure a patient's adequately resuscitated prior to pushing drugs.
Wanted to review the different type of laryngoscopes that are available in performing laryngoscopy. The major divide up front is video versus direct laryngoscopy, and we'll go through the different options that are available to you. With direct laryngoscopy, it's relatively simple in terms of options. There's two types of direct laryngoscopy blades. There's the Macintosh or curved blade that is traditionally used in adults, and it utilizes the hypoepiglottic ligament to lift the epiglottis off the glottic structures to allow visualization of the chords. Opposite of that is the Miller blade, which is a straight blade, traditionally used in pediatric patients with an underdeveloped hypoepiglottic ligament and a large floppy epiglottis. We use this blade to lift the epiglottis off the glottic structures to allow visualization of the chords. The laryngoscopes range in size, but generally an adult patient is going to use a size 3 or 4 blade. People have different preferences in blade size. It's a personal choice, and you need to be comfortable with whatever blade size is your first line option. In terms of direct laryngoscopy, the entire premise of direct laryngoscopy is to use a tool that allows you to create a visual access that allows you to look around the oropharyngeal corner to insert an endotracheal tube through the glottis. You can see there's 3 different axes we typically think of. There's an oral axis, a pharyngeal axis, and a laryngeal axis. And ideally, we're creating an environment with direct laryngoscopy that allows us to align these axes with one another. We often can't do this perfectly, but we try to get the oral, pharyngeal, and laryngeal axes as parallel as possible, and direct laryngoscopy provides us with a means to do so. A common issue is with laryngoscopy is just getting the blade in the oral pharynx. With patients who have redundant chest tissues, this can be an issue. All we want to do is introduce you to the fact that there are different types of blades available. Of note here is a stubby blade or a short blade, which can be helpful in the patient with redundant chest tissues. One tip that's been utilized in the past is disconnecting the laryngoscope blade from the handle itself, inserting the blade in the mouth, and then reconnecting these devices. Everyone will find different ways to work around tight working corners that are produced by redundant chest tissue, but just recognize that there are different blades for laryngoscopes that are available to you.
Next, going on to video and fiber optic laryngoscopy. The concept with generally with video blades is that they each provide you with an opportunity to visualize the glottic structures where it may be difficult or impossible to visualize with direct laryngoscopy, going back to the line of sight axes that Jake was talking about. There are many shapes and sizes, and it's important to note that these do not all function the same. There are some small motor differences in using each of these devices, so whichever center you end up practicing in, it'll be important to become familiar with the particular video device that's stocked in your emergency department. There are, in general, 2 big classifications: the standard geometry video laryngoscope blades that function very similarly to direct laryngoscopy, and then there are also hyperangulated blades that function very differently and allow you to kind of look around the corner, so to speak. At LHSC, we currently stock video versions of both hyperangulated and standard geometry blades, which we'll go into later on. Just in general, some of the advantages of video laryngoscopy is that it does negate the need for direct line of sight of the airway. It helps magnify the view of the airway for the entire team and allows your assistant to visualize what the intubator is doing. Generally, they may require less force to intubate when used appropriately. And it obviously allows for supervising practitioners and airway assistants to be able to be involved in the procedure when they're not the ones holding their laryngoscope.
In terms of options for endotracheal tubes, there are a variety of different tubes available on the market. For an adult patient in the emergency room, you're typically going to use a single lumen cuffed endotracheal tube. Sizes are variable. They range from 6 to 8. Usually you're going to be in the range of a 7 to an 8, depending on the patient's sex and age. For pediatric patients, you may consider using uncuffed endotracheal tubes, and we'll elaborate on this more in the pediatric airway screencast. In the OR and ICU, you may see double lumen tubes or armored tubes being used. We won't get into specifics about these tubes, but it's important to recognize that these do exist and are options in very specific contexts, which you'll come across in your studies.
Next is talking about the actual devices that we use to help deliver an endotracheal tube through the laryngeal inlet. In general, the standard of care in Canadian centers has been to use a stylet, as they provide a rigid structure around your endotracheal tube and allow you to basically shape your endotracheal tube to fit the patient's anatomy. The downside of stylets is that they're big, they're opaque, and in patients who have a tight or small airway, you do end up basically blocking the view of the laryngeal inlet, which you're trying to intubate. So it does make it more difficult. Many of you know that I am a big proponent of the bougie, and this is standard of care in many other countries in the world that I've worked in. And I've now made the bougie my standard equipment for every first intubation attempt that I do. Generally, these bougies are very long devices, anywhere from around 50 to 60 centimeters. They're narrow at about 5 millimeters, and they have a small 40-degree coude tip at the end. Using a bougie allows you to maintain visualization of the laryngeal inlet during your intubation attempt. It allows you to confirm placement with looking for things like distal holdup and feeling for tracheal rings. And thankfully there is some new literature coming out from emergency department data which shows greater first pass success rates. But Jake and I would definitely advocate that people use bougies on all their first attempts at laryngoscopy.
In terms of capnometry, which is a tool we use to confirm endotracheal tube placement, there are two options. There's color metric, which is visualized on screen left, and then quantitative waveform CO capnography, which is on screen right. It's important to be comfortable with both of these devices, although we'd highly advocate that all intubations being done in the emergency room are used with adjunct quantitative waveform end-tidal CO2, as this is the standard of care for tube conformation. For the color metric capnography, prior to the exposure of the membrane, which appears purple on the screen, that membrane appears purple. When CO2 reacts in a chemical reaction with that membrane, it turns gold. So you hear gold for good. You can be fooled by this, as stomach contents can have carbonation or carbon dioxide present, and that can be falsely positive for 8 to 10 breaths. With a waveform capnography, there's really no false positive for the waveform that you're seeing on the right. If you see that waveform, you are rest assured that your tube is in the glottic structures.
Next, going on to supraglottic devices. In general, there are two big umbrella categories. There's the supraglottic devices, which are LMAs and iGels, which are kind of the newer generation. And then secondly, there are retroglottic devices, such as the Combitube and King LT. We'll have all of these different types of supraglottic devices available at our airway day, so we can practice with each device. Every center EMS service will stock different supraglottic devices, so again, just become comfortable with whatever is stocked in your emergency department. All the supraglottic airways do share some of the same characteristics in that they usually have a gastric insufflation balloon. They're meant to be inserted blindly. Excluding the iGel, the other supraglottic devices all do require some sort of inflation of a distal mask or balloon to help facilitate a seal. But these are all rescue devices which we're going to use if our laryngoscopy fails and the patient is a difficult bag mask ventilation and our patient is still desaturating. Again, we'll play with the different types of supraglottic airways at airway day.
We're going to shift gears now to the second P of the 7 Ps of RSI. We've now talked extensively about preparation and the different tools available to you, and we're going to move on to pre-oxygenation. Pre-oxygenation is such an important concept to airway management that we actually have a whole screencast dedicated to this, so we're not going to review this extensively in the RSI screencast. That information is available to you in the Goals of Airway Management screencast, and there's going to be an extensive discussion about different pre-oxygenation strategies, so look for that in that screencast. But don't forget that pre-oxygenation is a very important step in proceeding with an RSI. Next is hemodynamic optimization and disease-targeted pre-treatment. So what we mean by hemodynamic optimization is trying to bring someone's hemodynamics back to a normalized state prior to proceeding with an induction agent, as they can be quite deleterious in terms of hemodynamics. This, we commonly think about this in the presence of hypotension in a shocky patient, whether that's hypovolemic shock from sepsis or hemorrhagic shock in the setting of trauma. You may augment someone's blood pressure with IV fluid boluses, with blood products, or an element of vasopressor support. It's important to recognize that any induction agent is going to reduce sympathetic outflow, and also some are vasodilatory, which can worsen a pre-existing hypotensive state. So we want to focus on bringing someone's hemodynamics back to some element of normal prior to proceeding with intubation. The other thing to consider is the transition to positive pressure ventilation can also worsen someone's hemodynamics, especially when there's pre-existing hypovolemia. The same is true for hypertensive emergencies. If you're proceeding with an intubation with a patient who's in a hypertensive emergency, you may be in a situation where you need to provide the patient with blood pressure lowering medications prior to performing an RSI, as the sympathetic reflex to laryngoscopy can be quite profound and worsen hypertension and cause a worsening of whatever disease process is happening. And next we talk about disease-targeted pretreatments, and historically there's been 3 diseases that we consider giving a medication prior to an RSI to prevent deleterious effects of the laryngoscopy or intubation, and those are asthma, cardiovascular emergencies, and traumatic brain injury.
And I think it's important to just take a second and pause here that unless we're talking about the very rare case with a patient who's got a complete airway obstruction and is peri-arrest, you always have some time to try to optimize your patient for this RSI. Like Jake said, the combination of sedative agents, paralysis, switch to positive pressure ventilation can all have deleterious effects on various disease processes. So unless we're talking about that very rare patient who's got a complete airway obstruction, you always have time to set up and try to optimize your patient for your RSI.
Although I previously said there are 3 disease states that we consider for pre-treatment, and you see them here: asthma, traumatic brain injury, and cardiovascular emergencies, there are really 2 medications that we consider in pre-treatment of these conditions. The first is lidocaine. The dose of lidocaine for pre-treatment is 1 to 1.5 milligrams per kilogram, and it's thought to diminish reflexive bronchospasm that can occur in patients who have reactive airway disease. It's also thought to reduce the sympathetic response to laryngoscopy, so we consider the use of lidocaine in both asthma and traumatically brain injured patients. Fentanyl is thought to reduce the reflexive sympathetic response to laryngoscopy, and for this reason it's used in patients who have traumatic brain injury or those who have significant cardiovascular disease who cannot tolerate a significant shift in their hemodynamics. The dose for fentanyl is 3 to 5 micrograms per kilogram, so it's a relatively high dose, and both of these medications need to be given 3 to 5 minutes prior to proceeding with the induction of the patient, so it does require some forward thought process when you recognize that a patient's heading down an intubation pathway. It's important to recognize that the evidence for both of these medications is very soft, and there's a lot of practitioners that do not believe that the evidence is sufficient to be giving these medications as an individual choice, and you'll have to review the literature on your own before you make that decision, and we're happy to discuss our opinions on the day of Airway Day.
Next, getting to induction with paralysis, there are a few obvious things to consider in terms of medication selection. So firstly, with respect to your induction agents, you want to choose an agent which will provide anesthesia, analgesia, and amnesia. You also want to follow that up with a neuromuscular blocking agent, which will relax the patient's tissues and allow you to manipulate the upper airway tissues to obtain that direct line of sight. Both the induction agent and the neuromuscular blocking agent have to be dosed adequately to promote a full loss of consciousness and paralysis. And importantly, the doses of each of these agents needs to be altered based on the patient's preceding hemodynamics and level of consciousness. Here are some of the common induction agents that we'll use in the emergency department for intubation. Propofol, ketamine, and etomidate, with their typical dose ranges described here. This needs to be taken with the caveat that these very standard dose ranges can be changed quite drastically in a patient who is hemodynamically unstable or having a hypertensive emergency. So although these are the usual doses you'll see written in textbooks and in charts like this, know that you should be altering these based on your patient's physiology. I personally like to use the shock index, looking at the ratio of the patient's heart rate to systolic blood pressure. It's always a bad thing when your heart rate is greater than your systolic blood pressure, and it's a very cursory marker that I use in conjunction with other elements of patient's physiologic markers to try to titrate my drugs appropriately.
Next, we're going to talk about neuromuscular blockade, and although there are an array of different paralytic agents available for a rapid sequence intubation, there's really two paralytics that you're going to choose from. The first is rocuronium and succinylcholine. Rocuronium is a non-depolarizing neuroblocker, and succinylcholine is a depolarizing neuroblocker. What that means to you is when you push succinylcholine, you're going to see fasciculations in the muscle tissues, and in rocuronium you will not experience this fasciculation. The dose for rocuronium is 1.2 milligrams per kilogram, and its onset is 45 seconds. Rocuronium lasts for 45 to 50 minutes. Succinylcholine's dose is 1.5 milligrams per kilogram. Again, its onset is 45 seconds, but it's a much shorter duration, 6 to 10 minutes. There was a Cochrane review that looked at rocuronium versus succinylcholine for RSI, and the author's conclusion was that succinylcholine created superior intubation conditions to rocuronium in achieving excellent or clinically acceptable intubating conditions. However, when you looked at a subgroup analysis of patients who received the dose of 1.2 milligrams per kilogram of rocuronium, the finding was that the intubating conditions were identical. When you're in the operating room, the typical dose of rocuronium used is 0.6 milligrams per kilogram, and this does lead to a delayed onset of action of this medication, but when you use a dose of 1.2 milligrams per kilogram, which is what we advocate, you do see that the onset of action is very similar and comparable to succinylcholine. One note is safe apnea times, and there's been some research in terms of which paralytic agent provides prolonged safe apnea times, and it appears that rocuronium has longer safe apnea times than succinylcholine. For an ASA grade 1 or 2 patients with BMIs of 25 to 30 receiving general anesthetics, patients who were given rocuronium took 40 seconds longer to fall to an oxygen saturation of 93% when apneic when compared to those who received succinylcholine. The theory here is that succinylcholine causes fasciculations, which may increase oxygen consumption in comparison to rocuronium, which does not cause that same increased oxygen consumption through fasciculations.
Looking at the contraindications and special considerations for using either rocuronium or succinylcholine, this slide kind of goes through some of the things that should go through your mind. This slide is focusing strictly on succinylcholine and its general risks, which include hyperkalemia from fasciculations, bradycardia, prolonged neuromuscular blockade in neuromuscular diseases which cause receptor upregulation, malignant hyperthermia, trismus, and master spasm. We could go into each of those in more detail on the actual airway day itself. Ultimately, this slide for rocuronium would essentially be empty, with allergy to rocuronium being really the only true contraindication or special consideration for its use. I'm a big proponent of cognitive offloading in difficult situations, and I think I speak for both Jake and I when we would advocate for the use of rocuronium in the vast majority of RSIs that are done in emergent situations. There are instances where succinylcholine may be a better agent, where masking seizure activity would be dangerous after your RSI. But outside of that situation, we would really advocate to keep things simple in this and use rocuronium at an appropriate dose for most of your patients. Ultimately, the patients who we're intubating all require a tube to be passed through laryngeal inlet. And if you've already gotten to this point in your RSI where you've done your airway assessment and deemed them not to be difficult, or you deem that you can rescue yourself with a BVM, a supraglottic device, or a cricothyrotomy, you know that this patient's going to get their tube. So also the benefits of ROC is that this patient won't be waking up during your second, third, fourth attempts, that they are optimized all the way through until they are safely intubated.
Now that we've talked about our drugs, we want to talk about the next P, which is positioning. This is probably one of all the P's are extremely important. My personal opinion is that this P is often overlooked, and when airways go awry, this is often one of the common issues that we see. So we want to review ideal positioning of a patient for laryngoscopy. Pre-intubation positioning essentially has four steps in the positioning mantra. The first is ear to sternal notch and face forward. So you want to bring their ear up to the sternal notch in a sniffing position, and you want to keep the face parallel to the ceiling or just slightly tilted back. The face should not be cranked way back in hyperextension. You want to bring that neck into a bit of a flexion position so that the ear is level with the sternal notch, and this will change. The requirements of ramping will change depending on the patient's body habitus, and we'll show you some pictures of that next. The second is the head of the bed up. So if you want to place the head of the bed into a 30-degree position or place the patient in reverse Trendelenburg, this is particularly important in patients who have high BMIs, in late stages of pregnancy, or people who are in spinal mobilization. This offloads the thoracic cavity and keeps the abdominal contents away from the diaphragm, which will increase your functional residual capacity and lead to increased apnea times. The next is a simple thing that's often not done, which is bringing the head of the patient up to the head of the bed. It just makes performing laryngoscopy easier. There's less reaching. Ergonomically, it makes much more sense. You want to make sure that your team has 360-degree access to the belly and the patient. This helps with accessing your different tools and equipment needed to perform this procedure. And you want to raise the patient up, so about your belly button or belt height, which will make laryngoscopy easier to perform. And then finally, you want to make sure your equipment and your assistants are ready to perform laryngoscopy. This is a pretty profound picture of the degree of ramping that may be required in a patient depending on their body habitus. You can see in that supine position how low the ear is, and compared to sternal notches, it would be a very difficult laryngoscopy to perform. But you can see the amount of blankets and towels required to ramp that patient adequately. And sometimes it seems excessive, but taking the time to ramp a patient in an appropriate manner will make your life a lot easier when trying to visualize the glottis.
I always take a moment during my setup to get my patient in what I think is an appropriate position, and then just go over to the side of the bed and take a look down at kind of bed level, just to make sure that the ear and sternal notch line up. If you can do this with ramping prior to inserting a laryngoscope blade, the actual force you're going to require will be much less, and you're already doing a lot of the work up front.
I spoke earlier about positioning a patient appropriately and that reducing or extending the amount of time for safe apnea. And this is a study that compared having a patient in 20 degrees of head up or supine positioning and the time it took for desaturation to 95%. You can see that patients in 20 degrees of head up had a significantly longer time of safe apnea before they desaturated to 95%. Your options here again for offloading the abdominal contents is having the patient with the head of the bed up or reverse Trendelenburg. We want to avoid supine positioning as much as possible, and although trauma patients will be immobilized, you can always place that patient in reverse Trendelenburg to reduce the amount of abdominal weight on the diaphragm.
Next up, we'll talk about placement with proof, and this is passing your endotracheal tube through the cords and ensuring that it's in the right position. With regards to placement with proof, we think of direct laryngoscopy as a very gentle, stepwise approach from inserting the laryngoscope into the patient's mouth to firstly trying to find the epiglottis as your first major anatomical target of the airway. Next, placing the tip of the blade into the vallecula, lifting forward, exposing your laryngeal inlet. Next, delivering your bougie or styleted tube. And then lastly, confirming placement with waveform capnography. We'll take you through some videos and some anatomy now.
Really quick anatomy review in terms of what you're going to be visualizing when you see the glottic structures. On screen left, we have a diagram. On screen right, we have an actual visualization of a real glottis. At the screen top, you'll see your epiglottis, and at the base of the epiglottis, you often do not visualize this, admittedly, but there is the hypoepiglottic ligament, which is what you're trying to utilize performing direct laryngoscopy with your laryngoscope tip, using that to lift the glottis or the epiglottis off the glottic structures. Next, you have the vocal cords, the pearly white cords, which you're looking for, and in between the glottic opening. Posteriorly, you have your arytenoid cartilages, which will often, if you can visualize your arytenoid cartilage, you have a decent chance of securing your tube because you know the direction that you need to target. And then you have your piriform fossa on the lateral sides.
Here's a video showing a nice, slow, gentle RSI where the operator here is slowly walking the laryngoscope down the back of the tongue and slowly walking until the epiglottis is visualized. The big floppy structure, that's going to be your first major marker that you're in the right anatomical space to expose the vocal cords.
The next is valleculoscopy. So you're going to, once you visualize the epiglottis, you're going to insert your direct laryngoscope blade into the vallecula. And you can see here that if you lift too early before you engage the hypoepiglottic ligament, the epiglottis doesn't move. Once you engage that ligament, small amounts of pressure can lead to dramatic changes in the epiglottic or the epiglottis location. So make sure that you're inserting your blade deep enough, and if you're not getting the desired lift in the epiglottis, you may need to insert your direct laryngoscopy blade a bit deeper in the vallecula to engage that ligament.
What I tend to do here is, once I visualize the epiglottis, I advance the laryngoscope blade, lift. If I don't get an appropriate visualization, I advance a few more millimeters, lift. Advance a few more millimeters, lift. And just do that in a slow, stepwise progression until I've engaged the hyoepiglottic ligament, like what Jake's talking about. This video here shows the benefits of a head lift in getting visualization of your vocal cords. Much of this can be done up front with placing your patient in an ear to sternal notch position, but this head lift where you are ear to sternal notch, face plane parallel to the ceiling, you'll really help align those axes we talked about earlier in the lecture to permit passage of your endotracheal tube.
When you perform all of these maneuvers appropriately and you're still unable to visualize glottic structures to your liking, the next move is to perform bimanual laryngoscopy or external laryngeal manipulation, ELM. You may have heard of this previously described as burp, back up and to the right. However, we want to reframe that terminology to external laryngeal manipulation because although commonly you are manipulating the larynx back towards you and to the right, sometimes it's a different direction that's going to bring that glottis into structure. We want you as the intubator using your non-dominant hand to move the glottis around or the laryngeal cartilage around on your own, and then once you have adequately identified the glottic structures by performing external laryngeal manipulation, at that point you take your assistant's hand and ask them to apply the same amount of pressure to keep the laryngeal or the tracheal cartilage in the position that you have achieved. This is a really important maneuver when you are unable to achieve an appropriate view, and it's important for you as an intubator to be using your non-dominant hand because your assistant cannot visualize what you're seeing when performing your laryngoscopy.
In terms of the Sellick maneuver, this was a maneuver that was traditionally taught of in emergency RSI, where cricoid pressure was applied to occlude the patient's esophagus and decrease gastric insufflation. MRI and ultrasound-guided studies have since shown that rather than occluding the esophagus, cricoid pressure rather displaces the cricoid and the laryngeal inlet, and it reduces the anterior-posterior diameter of your vocal cords and makes intubation much more difficult. It increases the time to intubation and produces an inferior Cormack view. Even in patients who are not fasted, Jake and I suggest abandoning cricoid pressure completely. Oftentimes, it's not well taught. Airway assistants can be putting cricoid pressure on the wrong structures and rather pushing down on the thyroid cartilage instead. Because the evidence suggests that it does increase your time to intubation and decreases your view and does not prevent aspiration, Jake and I would advocate that you abandon the Sellick maneuver in your standard RSI.
Another issue in terms of placement with proof is the shape of an endotracheal tube. We want you to shape your endotracheal tube to the way that you are most comfortable with in using a stylet. Often the respiratory therapist in assistance in preparing your equipment will place particular curves or shapes in your endotracheal tube. We want you to use whatever curve you're most familiar with and comfortable with. We would advocate a straight to cuff tube, which means you keep the tube entirely straight till you reach the balloon, and then you place a 30-degree angle. There is evidence that this shapeage of an endotracheal tube leads to increased first pass success rates and less resistance when performing an RSI. That being said, if you are used to a different angle and you're more comfortable with a different angulation with your endotracheal tube, fine, so be it, but place that shape yourself and ask RT not to adjust your angulation, because if you're handed a tube that has a strange angle to you, it's going to lead to difficulty in manipulating the tip of the tube and passing it through the glottis.
Next up, talking about just quickly about this JAMA study, which looked at the use of a bougie versus a endotracheal stylet on first pass success rates in emergency intubation. This was an RCT done at an academic center, and long story short, first pass success rates were 12% greater in the bougie group with no increase in complications, leading to a number needed to treat of only 7 to increase your first pass success rates. So again, it's nice to actually have some hard evidence, which confirms what Jake and I have thought about the bougie prior to this. Make this your standard piece of equipment on your first pass attempt every time, and then when you do get those rare airways that are a little bit smaller due to airway burns or edema, where you have a true grade 3 Cormack view and only see epiglottis, the bougie can really be a life-saving piece of equipment. And it's important to be comfortable using it. Even though it isn't a complicated piece of equipment, there are some small tips and tricks to using it appropriately. In terms of the most common error or difficulty we see with the bougie is that once the bougie's through the cords and an endotracheal tube is being railroaded over top, the tip of the endotracheal tube may get caught up on the retinoid cartilage as you're trying to get it through the vocal cords. Here, if this ever happens, just continue to maintain a view with your direct laryngoscope in its usual position, and rotate the endotracheal tube 90 degrees to get the bevel up, and it should pass through over the arytenoids fairly easily. Using a bit of ELM at this position may also be favorable to decrease any kind of hyperacute angle that the bougie has taken to go through the cords.
We'll take a quick break to talk about communication strategies when performing laryngoscopy. Particularly as learners, you're going to be asked to describe what you're visualizing. And there are essentially two methodologies in terms of describing what you're visualizing in terms of glottic structures. The first and more commonly used system is on screen right, the Cormack view. There's essentially 5 grades to a Cormack view, grade 1 through 4. They say there's 5 grades. This grade 2 is split into a 2A and 2B, and it's actually quite important to differentiate between a 2A and 2B. 2A, you're seeing some element of cords along with your retinoid cartilage, and 2B, you're only visualizing the retinoid cartilage. Being familiar with the CORMAC system is important, as most physicians are comfortable using and communicating this way. However, on screen left is a visualization of a system called a POGO, or percentage or glottic opening, which describes the amount of glottic structures that you're able to visualize. We prefer a POGO system as it's more intuitive in terms of what you're visualizing. However, there are a lot of physicians that are unfamiliar with this communication strategy, so don't be shocked that if you say you have a POGO of 25% and your consultant has no idea what you're talking about, then you may need to elaborate later on, but being comfortable with both is very important.
Next up, we'll talk about video laryngoscopy and just some of the common elements of using these devices correctly. The most common error we see with video laryngoscopy is that learners, for good reason, want to achieve a grade 1 view. But actually with video laryngoscopes, that does tend to make intubation a little bit harder, as having the camera blade right up against the glottis produces a much steeper angle. Remember, with a lot of these hyperangulated video laryngoscopy blades, you have quite a steep angle that your styleted endotracheal tube needs to navigate. So by having the tip of the blade and the camera really close to the glottis, it makes this much more difficult. What we advocate here is to advance the video laryngoscope, insert the video laryngoscope blade into the mouth, rotate around the tongue until you visualize the epiglottis. Continue to advance the video laryngoscope until you've generated a grade 1 view, but then back it out by a couple of centimeters, where you're essentially creating a bit of a soft grade 2 view, and this will make it much easier for you to be able to pass a styleted tube through. This is another view here showing the difficulty with picture A, having the video laryngoscope blade right near the epiglottis and the tip of the endotracheal tube kind of having a difficult time passing through, versus backing out a little bit and creating a more shallow angle where you can pass through your stylet.
The next P is proving tube placement. And we want to re-emphasize that waveform capnography is the gold standard for tube placement, with visualization of a standard end-tidal CO2 waveform. Chest X-ray, auscultation are helpful adjuncts. Both can be misleading. Both can lead to misplaced tubes not being identified. When you see a proper waveform with waveform capnography, you have clearly placed a tube in the glottic structures, and this is what we want you using from a gold standard perspective. In the emergency room, we do not want to see colorimetric capnography being used. We are trying to disseminate that to our respiratory therapists. However, you may need to ask them to place waveform end-tidal CO2. When you're in settings outside of the emergency room, in a pre-hospital environment or on the floor, colorimetric end-tidal CO2 may be the only thing that's at your disposal. It's important to recognize the possibility of a false positive colorimetric change, and you need to see that colorimetric change be persistent beyond 8 to 10 breaths to be confident that you're in the glottic structures.
Talking about the importance of first attempts, Jake and I have just spent the last hour or so going through all of the different steps of intubation, and at first to a novice intubator can seem kind of quite daunting. All right, why don't we just get some IV access, push some drugs, and go ahead and pass the tube. But everything that we're advocating for is trying to increase your chances of achieving first pass success. First pass success has been showed in multiple studies now, in review studies and in RCTs, to decrease intubation complications. With every successive attempt, we know bad stuff is going to happen, whether it be hypoxia, hypotension, trauma to the patient's airways or dental tissues. We really want you to take the time to set this patient up appropriately in advance, in a good position for yourself, for your team, and for your patient, so that you can maximize first pass success and decrease your intubation complications.
Before we talk about the last P, which is post-intubation care, we want to talk about the salvage airway algorithm. This is a situation where you have found that you have failed on your first attempt. You are now in a salvage airway mindset, and you need to take maneuvers to correct whatever the issue was with laryngoscopy. However, the first step in a salvage airway is determining whether you can bag, valve, mask a patient. Ideally, you've assessed the patient prior to the induction of paralysis, and you have not predicted that they have a difficult bag, valve, mask ventilation, and you're able to bag the patient to a SAT greater than 90. If you're able to do that, you have time, and you're now able to change something in terms of your laryngoscopy attempt, and we're going to go through the recommended algorithm. But before we do that, if you're unable to bag a patient to a SAT greater than 90, you are now placing an LMA or a supraglottic device. And if with a supraglottic device you are not able to achieve SATs greater than 90%, you're now moving towards a cricothyrotomy. You're in a can't intubate, can't oxygenate situation, and a surgical airway is now mandated. If you are able to bag a patient to SATs greater than 90 with an LMA, you have the option of leaving the extraglottic device in until assistance is present with anesthesia, or an attempt at intubation. Another attempt at intubation can be attempted. This is really going to depend on the clinical scenario that you're in and how readily available support is to you and how difficult the laryngoscopy was. If you are able to bag someone to a SAT greater than 90% after your first attempt, you're now going to change something. The standard algorithm for most patients prior to the bougie literature and the push towards bougie with first attempts is going to be a stylet and endotracheal tube. In that situation, we'd recommend that your attempt number 2 is direct laryngoscopy with a bougie rather than a stylet. However, that may be your attempt number 1 with increasing evidence that bougies are superior to stylets. If that fails, you're going to bag the patient again. You need to achieve bags greater than 90%. If you can't, you're now on the left side of the screen where you're placing supraglottic devices. If you fail on your second attempts, your bag, valve, mask ventilation is adequate and SATs greater than 90, you're going to attempt a third time with video laryngoscopy. If this fails, you are going to be placing an LMA and seeking assistance. Greater than 4 attempts at an airway is highly unlikely to be successful. So if you're unable to achieve an endotracheal intubation after 3 attempts, our recommendation is to put an LMA in, oxygenate and ventilate the patient well, and get further assistance in managing this airway.
Yeah, talk to your team during your airway plan before you've actually pushed drugs. And Jake and I always talk to our team, and we agree upon a predetermined SAT in which we're going to stop our intubation attempt and re-bag the patient with an oral airway, nasal airway, a good 2-hand technique back to an appropriate SAT. Right? If that SAT is continuing to fall with a good BVM, next step is LMA. If it's still falling, next step is cric. Ultimately, if you're not prepared or have not kind of made the decision in your mind prior to starting the intubation that you may end up doing a cricothyrotomy, do not push the rocuronium. You're just not ready. Take the time and palpate that every patient's cricothyroid membrane, because ultimately that's going to be your big safety umbrella if all of this fails. Right? If you fail your first attempt and you're able to bag a patient back up to appropriate SATs, take a moment, take a deep breath with your team. Now you have time to actually discuss what attempts 2 and 3 are going to look like. It's hard in these algorithms to say exactly what you should do. If in your first attempt with a DL, the only issue was that you had a good view of the epiglottis, but your blade just wasn't long enough to engage the hyoepiglottic ligament, well, it's reasonable in your second attempt to also use a DL, but with a Mach 4 blade instead of a Mach 3. If the issue was that you only got a grade 3 view because you were unable to align the oral axes in your first attempt, then a hyperangulated VL may be your next best tool. So ultimately, none of these algorithms are going to be perfect at saying what you should do in subsequent attempts. But ultimately, if you can come up with an airway plan with your team to abort an airway attempt at appropriate SATs before the patient becomes dangerously hypoxic, reoxygenate the patient, ventilate them, and now you got some time to actually plan attempts 2 and 3. Going on to post-intubation care. So we've now successfully passed our endotracheal tube there's a big sigh of relief in the room. Just remember that your job and your team's job is not done yet. There's still a number of things that need to happen to safely care for this patient, right? So we've confirmed placement with end tidal capnography, like Jake talked about. But now we're ultimately going to get a chest x-ray to make sure the tube is at an appropriate depth and able to oxygenate and ventilate both lungs. We're going to insert an OG or an NG tube to decompress the stomach and reduce aspiration. This patient, although they received a dose of a sedative during the actual RSI attempt, it's now time to start this patient on a sedative infusion with an appropriate drug and an appropriate dose to keep them comfortable and control their physiology. Ultimately, we advocate that all of these patients get transitioned from a BVM to a ventilator so that we can deliver regular, safe breaths at appropriate pressures for the patient in front of us and decrease lung trauma. We're going to increase the head of the bed elevation if possible in your patient to decrease further pulmonary complications like ventilator-assisted pneumonias and aspiration. And then we're going to correlate our end tidals and our blood gases together to make sure that we are titrating our minute ventilation for the patient on the ventilator to an appropriate setting.
To summarize what we've gone through in the last hour, we talked about predictors of difficulty in terms of laryngoscopy, bag valve mask ventilation, extraglottic device, and cricothyrotomy. As you become more experienced in managing airways, these predictors are going to become more innate and you're going to be reliant less and less on mnemonics. However, as you're gaining experience, it's important to have a structured assessment of a patient prior to managing their airway to look for these predictors of difficulty. We talked about the 7 P's of rapid sequence intubation. Preparation is essential when managing an airway. It's essential when performing any procedure, and it's often the determinant of success or failure. So taking time to prepare your room, your equipment, and your team is going to pay dividends in terms of success when managing airways. We have delayed sequence intubation for the agitated hypoxic patient. We're going to talk about this much more in another screencast. We didn't talk about it during this one, but just recognize that in hypoxic patients who are agitated, taking time to pre-oxygenate them adequately is important. And again, we will review that more in different screencasts. Knowing your salvage airway plan before drugs are pushed are very important, both for your mental model and your team, so that everyone is knowing the next step when an airway attempt fails. We hope you guys learned something by watching the screencast. We look forward to seeing everyone on the Airway Day. Please bring questions so that we can have group discussion about different airways that you've managed, different questions you have about the information that we've shared with you in this screencast. We do appreciate you taking the time out of your day to watch this.
Thank you, everyone.